Bloodstream infections.
Blood cultures. When we have the presence of bacteria or fungi in the bloodstream, that is indicative usually of a severe infection. Diagnosis would typically involve drawing blood for blood cultures. Some definitions, so we have bacteremia. That's defined as the presence of viable bacteria in the blood, where sepsis or septicemia is defined as patients showing clinical signs that indicate an infection, such as fever, chills, or hyperventilation. In bacteremia, we can have transient, intermediate, or continuous. A transient bacteremia is a small number of organisms that enter into the blood during a procedure, where intermediate could be an entry of organisms into blood from an extravascular site. So think of a patient that maybe has like a central line or something, a PICC line, something like that. Continuous entry is going to be from an intravascular site of infection. There is some more information in your textbook that will kind of show some commonly isolated organisms from these. Specimen collection. So when we collect blood specimens, our specimens for blood culture or the volume of blood for the blood culture is very important, usually because we have a low number of organisms. So it's important to make sure that we decontaminate the area prior to the venipuncture. We don't want normal flora in there since we have a small number of organisms to probably try to get from the blood to begin with. Your culture media is usually a trypticase soy broth, and you will have one bottle that would be processed as aerobic and another bottle that's going to be processed as anaerobic. Both broths will contain the anticoagulant sodium polyethanol sulfonate, or SPS. Generally, for blood cultures, we do not draw from an IV or catheter port or from the arm receiving the IV. So the reason for that is the catheter and port, IV, things like that could be contaminated itself. And then also, we don't want the blood to be quote unquote diluted from any IV fluid either, since again, it's a small amount of organism that we're trying to collect. We don't need the help of a dilution to make that even smaller. SPS. So if you don't draw directly into the bottles, you can draw with the yellow top tube. So if you think about the order of draw, you talk about yellow or the sterile tubes being drawn first. So when there's more than one type of yellow top tube, make sure you pay attention to what the SPS as an anticoagulant actually does as it functions. So what it does is it will inactivate certain antibiotics, although we do hope that the blood cultures are drawn before any antibiotics are administered. It will also interfere with any phagocytosis, and it will also inhibit complement, which are all good things because that's the immune system attacking the organism, which we are hoping to recover so we can identify, what's causing the patient these symptoms. The drawback of SPS, though, is that it also inhibits certain bacterial growth, and that would be things like Neisseria gardnerella or Peptostreptococcus, which is an anaerobe. The collection technique for blood culture should be a two-step disinfection. The two-step disinfection generally is a 70% isopropyl alcohol on the patient, and you can use iodine as well if the patient's not allergic to it, though a lot of places have kind of started to go away from that and using like a ChloraPrep type disinfectant with that. So for adults, we will generally draw anywhere from 10 to 30 milliliters of blood per bottle. With a child, you want at least 1 milliliter to be put into the bottle. They do make pediatric sized blood culture bottles that will be available to you. Your ratio is about a 1 to 5 or a 1 to 10 to broth. So the blood is about 10 to 20% of your final volume. Some facilities are going to draw 2 sets, while others are still drawing 3 30 minutes apart. The drawback to doing 3 is that you're delayed an hour or more of that patient getting antibiotics because they have to wait for us to come back and draw and then come back again. So a lot of times now they have changed to 2 sets from 2 different sites. So if the patient has a viable venipuncture site in both arms, go for it at that time. You can get it done, and then they can start the antibiotics right away. You can draw from one arm. Generally, you'll cleanse the site and then draw from the second arm. And make sure you're labeling these bottles as soon as you're done collecting them as well. No different than any other type of blood draw that you are doing.
Some hospitals choose not to perform anaerobic blood cultures due to the low recovery rate of clinically significant anaerobic organisms from blood samples. When available, pediatric-sized blood culture bottles should be used for samples from children or patients with limited blood volume. It is important to avoid collecting blood cultures from intravascular lines, as this can increase the risk of contamination and false positive results.
In general procedures, we have a manual versus automated for identification of positive blood culture bottles. With the manual option, we are going to still rely on that traditional media that could be like a slab of agar that's inserted into the top of the bottle. And so when you mix your bottles, you're actually going to bathe the agar with that blood broth mix. A lot of times that will accelerate the growth of the organism, and that's going to then be referred to as a septi check paddle. There's also an isolator system out there that will lyse the red cells, and then specimens directly plated will give us positive results sooner as well. And then what a lot of people kind of have been seeing lately is an instrument-based system. So think of Bactec. It seems to kind of be the manufacturer that most are going to be familiar with. It has a sensing system that will depend on different things, whether it's a colorimetric change, a change in the amount of carbon dioxide that's a product produced of, or a metric signal that correlates with positive blood cultures. So the picture there is kind of an example of that. So you put the bottles in there and it incubates it for you, and then it will give out an alert for you to know that you need to go check it if one of those metrics is met. For processing positive blood cultures, it's really going to happen when there's any evidence of any growth. So we've already talked about in culture sites, if there's hemolysis, gas, bubbles at the top, any fluff balls, turbidity, if the septum is bulging of the stopper of the bottle, that will indicate if there's gas production in there. All of those are evidence of growth. So you're going to go ahead and pull and mix your bottle within the hood because it could spray out, and it will. So you're going to aspirate with a needle and syringe. And then from there, you're going to do a gram stain. And once you do that, once you see an organism on the gram stain, it's going to become a critical value that's going to need to be reported out. They do the gram stain first because they try to give the clinician as much information as quickly as possible, so we can try to, get the patient feeling a little bit better, a little bit quicker. So we've already talked about evidence of growth. Again, critical values are called, um, to the clinician or the charge nurse, and make sure, again, that you are noting the time, date, who took the message of that as well, depending on your facility and what their protocol actually is. And then from there, you're going to subculture your plates depending on what your gram stain results revealed. And that will also kind of depend on your facility as well. When we reinterpret results, one of the things that we do is we have to be cognizant of what is possible contamination in this culture. So skin flora, so if you think bacillus species, corynebacterium species, coag staph in one, but maybe it's in several cultures. You need to think, do we have growth of multiple organisms? That's more than likely contamination, but maybe the clinical presentation of the patient doesn't indicate sepsis, so that's where the clinicians have to correlate lab values in patient presentation or their symptoms. You have to also know the organism at a primary site is not the same as a blood culture. Organisms, oftentimes, if you have like a really, really sick patient, the same organism can be recovered from a urine and a sputum, as well as blood. So sometimes you need to make sure that you can do some correlation of the organisms if you have a patient who's extremely, critically ill, and you can kind of correlate your results from there.
A probable pathogen is indicated by the growth of the same organism in repeated blood cultures. It also includes the isolation of organisms from patients suspected of endocarditis, such as enterococci and gram-negative rods. Growth of certain bacteria like Enterobacteriaceae, Streptococcus, pneumonia, gram-negative anaerobes, and Streptococcus pyogenes is considered significant. Additionally, isolation of normal flora organisms from immunosuppressed patients suspected of bacteremia should be treated as probable pathogens. Blood culture reports are typically provided at 24 and 48 hours after incubation. The final report is issued at the end of 7 days, as all negative cultures are held for this duration to ensure no growth. When reporting, it is important to clearly state no growth after X amount of days or hours to indicate the length of the observation period.
Sources of your pathogen, they could have come from respiratory, genital urinary, or intestinal tract. Your common pathogens are going to be Staph aureus, coagulase negative staph, E. coli, Enterococcus, could be a yeast, could be Strep pneumo, Pseudomonas aeruginosa, or Klebsiella pneumoniae. So again, we do need to evaluate if only one culture is positive. So that's why we typically draw a set of 2. That's information to the clinician to correlate with the patient symptoms. And if the patient has Staph aureus with acute endocarditis, that can result in death. Some special organisms that need to kind of be considered as well is that you have Candida, which is a yeast. You have Cryptococcus neoformans, which is normally recovered from the cerebral spinal fluid. But if you've got a patient with Cryptococcus meningitis, it could have crossed the blood-brain barrier. Histoplasma capsulatum is a dimorphic fungus that we'll talk about later. And then you have your Mycobacterium tuberculosis and Mycobacterium avium that also need to be considered for positive blood cultures as well.